Hey everybody, can everybody hear me? Good, thank you, great. All right, so we're gonna go ahead and get started. We have a couple of, I don't even know what to call them, but discussion points, not cases, but I'm totally happy with this. I'm gonna call them a case when I report this session. And then we have a didactic, and we'll do half of it today and we'll pick up half of it up the next time. But let's start with introductions real quick. Dr. Peters, do you want to start?
Hey, I'm Greg Peters. I'm a family medicine doc down in Buchanan with Community Care of West Virginia, and I have a resident with me from the Department of Family Medicine.
Hi.
That's Kyle. That's Kyle Miller. Dr.
Great.
Miller's with me.
Awesome, thank you. All right, and Dr. Soltis?
I'm Dr. Lucia Soltis with Lincoln Primary Care in Hamlin.
Awesome, thank you so much. Dr. Hirschler?
Hi, I'm Jeremy Hirschler. I'm an addiction psychiatrist at the Lakewood Center in G Lake.
Great, and Dr. Rexroad?
I'm Carmen Rexroad. I'm a family physician at Pendleton Community Care in Franklin.
Perfect, thank you so much. Dr. Rushton? Dr. Rushton, do you want to introduce yourself? Maybe you can't hear me, that's okay. All right, everybody at the Integrated Pain Clinic?
Minor technical difficulty. Rick Vaglianti, Physician Pain Center.
Nick Marcassani, chiropractor at the Pain Center.
Ed Prim, chiropractor at the Pain Center.
Julianne Spini, movement therapist, exercise physiologist at the Pain Center.
Awesome, thank you all. And I'm Caitlin Edinger, the Project Echo Coordinator. So, like I said, we have two kind of discussion points that we're going to talk about, and then I'm going to let Dr. Vaglianti start his overview didactic of spinal stenosis. So, Dr. Peters, I'm going to let you start, if that's okay.
Sure. So this is, I guess, kind of a last-minute case presentation. Just a guy that I've never felt like I've taken particularly good care of this guy. From a primary care standpoint, he's relatively straightforward to take care of. But from a comprehensive medical standpoint, he's somebody that's extraordinarily difficult to take care of. So this is a guy who is 38 years old. So he's actually my age. He is 5 feet 4 inches tall, and he weighs at least 500 pounds. He might weigh 600 pounds. He occasionally gets admitted to the hospital, and that's really the only opportunity that we have to get a weight on him. Last time he was in the hospital, he weighed about 580 pounds. He's a guy that suffers with chronic pain, mostly because of his body habitus. He's never really had any significant orthopedic trauma or issue, but just his constant state of immobility leads him to suffer from bad shoulder pain just from how he has to lie down in bed, and then back issues just from where he has to transfer and move around. So he's a guy that I actually do home visits for, and I see him every month because I prescribe opiates for him for management of his pain. He's on he's on Percocet. So he takes Percocet 7.5 milligrams 3 to 4 times per day. He's somebody that, I've done urine drug screens and pill counts and board of pharmacies, and he's never had any issue, any concern as far as diversion or misuse. But he's a guy that, and I've had a few patients that have been in situations like this, where what he really needs is he needs comprehensive medical attention from a psychiatric, a physiologic, a bariatric, a pain management, a nutrition and an exercise physiology standpoint. And I just don't really know what to offer this guy. He is a guy who has not he has not been able to, the reason I started doing home visits for him was because the last time I saw him in clinic, the last time I saw him in his office, I had to see him in his truck. Actually, I had to go out into the parking lot and see him because he wasn't able to get into the wheelchair and then get into our office. And so I started doing home visits for him, which is fine. And we've done quite a bit for him from a primary care standpoint, just updating things and staying up to date on his labs and that sort of thing. But I don't really know what to offer him. We've done home health, we've done weights, we've done food journals and food diaries and this sort of thing. But his just immobility, he's married, there's kind of a codependency relationship between him and his spouse. I mean, obviously people this big can't stay this big by themselves. So somebody's obviously bringing him food and giving him the calories that's keeping him this heavy. In the last year and a half, he has not left his house just because of his inability to ambulate. He has been out to his front porch maybe half a dozen times during that period of time, and that's maybe 15 steps from his bed to the front porch in his double wide trailer. And in the last 9 months, I don't think he has left his bedroom. Like, it's just kind of where he stays and where he hangs out. And so I just don't really know what to offer this guy as far, from a pain management standpoint. His pain is relatively well controlled, such as it is. He's had some chronic shoulder discomfort. We've actually given him a Toradol shot that provides him a great deal of relief, and he uses some just PO NSAIDs as needed, and that helps quite a bit too. He has obstructive sleep apnea, which obviously the risk of opiates and respiratory depression in somebody like this is his obstruction and restrictive lung disease are largely because of his body habitus as well. So I don't think from a pain management standpoint that's really going to do a whole lot for him, because it doesn't really change his level of functionality. It decreases his suffering. And that's been kind of the goal of his care. But I guess really the major question is, what do you do with people like this? They can't leave their house. I mean, the only thing that he could do, he'd have to go someplace that was residential, really. I mean, that would be the ideal situation for him. And I just don't know how to go about starting to do that.
Thank you so much for bringing it up. I'm going to let everybody else comment before I ask for input from everybody over at the Pain Center.
Well, this is a little bit out of my wheelhouse, but I'm a psychiatrist, so I certainly have some familiarity with bariatric surgery and binge eating disorder. There is a program at WVU at the Chestnut Ridge Center for the bariatric surgery program, a psychology program. Would there be any way that he could get to Morgantown?
No, it's okay.
Yeah, that's a great question. So realistically, I don't think so. Honestly, we have a pain management. So the way our company handles pain management for the most part is primary care physicians refer to our pain management clinic, and then the pain management clinic are the folks that prescribe those medications. That our pain management clinic is in Bridgeport. So when he became my patient originally, he came to me on already opiates. At that time, he was on, I think he was on Norco 10s like 5 or 6 times a day. And I had referred him up there, and he wasn't able to fit actually through the doorway to get into the clinic. So he wasn't able to see them. But the real problem was the trip from Buchanan to Clarksburg was about an hour, and it was so excruciatingly painful for him that it was terrible getting to Morgantown. I mean, I think he could get to Morgantown once, or I think he could get to Morgantown a couple of times. But that's what's so hard with him is I I don't know if there's going to be a real opportunity to make meaningful change for him without long-term treatment, really. And that's really kind of what I was, what I just don't know what to offer him, if there is anything really. It may just be a sad case.
Well, there is a program that is targeting people like this, but there has to be some motivation on his part to engage in the treatment and have the psychosocial support necessary to undergo the procedure and follow up with the appropriate diet. And this is not my specialty, so I don't know a lot about what they do, but there is a program for this at WVU.
All right. What's up for everybody?
Could I just add one thing? Greg, I mean, have your behavioral health people been in contact with this guy or out to see him, or with the family who's kind of enabling this? I mean, is that even an option? You know, you could do some intensive work that way?
Yeah, it's a good question. No, I mean, they've reached out to him just by phone and done some phone interviews and talked with him about, really what he wants to do. And he's one of those people, and I think at least as primary care docs, we hear this a lot or see this a lot. He's one of these people that when you have conversations with him, he seems extremely motivated. So you talk to him, he's like, yeah, I want to do this and I want to make sure that my diet is right. I want you to get me a diet so that I can really follow this thing and do this stuff. But then the weight doesn't really change, so then you have kind of a difference between kind of the subjective report and the objective measurable difference. You see it with diabetic, or at least I seem to see it with diabetic patients not infrequently. And so there seems to be some disconnect that's between that. And, we'll have conversations where, and everybody in the house is heavy, right? So like they're all, it's not nearly to this extent, but there's him and there's his wife and there's a child that they are raising, but is not biologically related. But I mean, you can tell everybody overeats, and so or eats improperly and doesn't get very much exercise. It's really, I should have mentioned too, he has these large, almost elephantitic lymphedema, like these massive, these large, like these peduncular, they're huge. I mean, absolutely enormous. And I think it's just essentially fat tissue that is just waterlogged with edema. And he has this chronic, kind of yeast, and then he'll get skin breakdown, and we'll treat that. And it gets better for a while, and it gets worse. And he's used, diflucan and nystatin powder, or if it seems to get secondarily infected, use antibiotics, all that sort of stuff. But God, like for this guy, even to exercise would be extraordinarily difficult. And so he would have to almost have, he would have to have intense dietary treatment. He would have to lose weight. He would have to have general surgery to remove these things, somehow remove these things, which I've never had a patient, undergo something like that. So I don't know what that looks like even. And then be able to maintain some sort of a treatment. It's so comprehensive and multidisciplinary. It's just, I don't really know where to begin, I guess, really with him as far as that goes. But yeah, from a behavioral health standpoint, it's a really good thought. I mean, he's on venlafaxine at 150 milligrams, and he takes Topamax 200 twice a day. The Topamax is more or less for he's getting headaches and that sort of thing, and plus it's got a little bit of weight loss associated with it. So I thought, well, why not? But so.
Hey, Greg, this is Rick Gross. I came in late to the conversation, and I'm sorry, but my original thought was going to tell you that the psychologist at Community Care Clinic in Bridgeport, Liam Condon, has experience in bariatric evaluation and treatment, because he was an intern of ours here. And so he's got pain background and some bariatric background as well. That being said, given what I heard, he's not going to exercise or diet away his weight. I mean, I mean, he is a bariatric surgery patient from the way you described it. And I think anything else we do but ignoring the elephant in the room is we're not going to be very successful.
I had wondered too, there's a medicine that, as far as weight loss medicines go, they are just really not part of my medical practice. Like, I just have I've never seen patients achieve long-term success with weight loss medication. There's a medicine called Belviq, which is like a serotonergic medication. It seems to help with satiety and overeating, and again, people like that. I don't know if he would be a patient. I don't know that I would be qualified really to do that. I don't know that. On the other hand, he might be a perfect patient to try something like that. I don't know. I don't have any experience. I guess I could reach out to Liam's great. Like, Liam's he's a really, really good guy too, and does good work. So, I mean, that's a really good thought.
I mean, you might want to start with him. He's got connections to the behavioral medicine people at Chestnut Ridge, that the psychologists that are on that team that do the evaluations, and he may be the person that can help guide that person into that program, and he can do the pain stuff to some extent, but also navigate the bariatric piece.
You could also try to contact Tria Haggerty in family medicine. She has a metabolic clinic, and she uses hypoglycemic drugs and other serotonergic agents for appetite suppression. So she may give you a hint how to jack up his metformin, Jardiance, Wellbutrin, but he's not going to be able to move on Earth. Unless you get him in the water or something. The thing about it is, if he minimizes his intake at all, as big as he is, metabolic rate, he's going to shed weight like crazy. But the question is to get him there. And the problem, I think you've done a great job, so don't beat yourself up over this. He has to participate in his care a little bit. You can't ride a bike for him, or you can't go swimming for him.
No, and honestly, Rick, we've had that conversation. If just as a rough estimate, his metabolic intake daily, just to maintain that weight, would be about 10,000 calories. And that's not coming, for somebody that's not leaving their house. I mean, even if you cut that in half, which is maybe 5,000 calories, be roughly twice what somebody his age should be consuming. Even if he was eating too much, he should be losing weight. So and we've had frank conversations about that. I am not somebody that beats around the bush as a general rule, and certainly not with this guy. I mean, I've been brutally honest with him in the past, is the fact that you're just eating too damn much, and it's not there's not any way around that. From a medical standpoint, there's so much that can be done. From a psychological standpoint, there's a lot of work that needs to be done. And then really from his participation standpoint, I think you're right on the money. I mean, he needs to do it too. And it's,
somebody ought to be able to, I mean, you send a therapist to his house, maybe they can start doing some chair work, with some little bit of weight, and that will jack up his metabolism also. Yeah.
Greg. Okay, I can't speak to what Dr. Bagalanti had said about using certain drugs to treat this person, i.e. Tria's clinic. I don't frankly know if she has dealt with somebody that massively big. Okay, I don't know. I would be surprised. How big? I came in with Rick. Okay, the other Rick. How big is this person?
He's somewhere between 550 and 600 pounds.
Okay, so even if you threw medicine at him, okay, I'll bet you dollars to donuts. I'm not trying to be cute. okay, with respect to the food issue, that it's not going to do hardly anything for him. I'm not even sure we have enough of the evidence to support drug therapy in someone who's 600 pounds, okay? Because of the weight loss studies that have looked at some of these drugs, you know, I mean, they're looking at modest weight loss with people that are not, you know, massive, like 500 or 600, 700 pounds, you know. So let's say you got a 10% weight loss, okay, on a 600-pound patient, okay, now you're down from 600, okay, to 550. You know, I mean, as Rick and I and here, you know, discussing this issue a little bit, you know, he's a surgical candidate. I mean, that's who's going to fix him. I don't think anything else is going to fix him. Yes, he has to pay attention to the calorie restriction component, and that's going to be that'd be part of the program. Okay, I'm not sure how much evidence we have to support drug therapy helping that. Okay,
you know, it's interesting, Charlie, too, because you know you mentioned that. So from a surgical standpoint, because I had actually referred him to bariatric surgery at WVU.
Yeah.
And what we were told is actually that he's too big, like that he's too.
Well, if he's too big
for bariatric, I don't know. I guess how. And it's not. There's not a clear answer because getting him to the initial appointment to really get that evaluation, actually get useful information, is so difficult. So,
Greg, did they have a plan B or did they just say too big, go away? Wow.
Yeah, unfortunately, that was kind of where. Yeah, it was kind of. It's frankly, it was a little bit disappointing, but it.
I'll tell you what I can do is I'm going to be in 20 minutes. I'm going to be back over at Chestnut Ridge in a room with the bariatric psychologist. And I'm going to ask them about the 500 or 600 pound patients that are told they are too big for bariatric, and what is there a recommendation that is typically given, and for some reason this didn't happen, and if there is something, I will let you know. Okay.
Yeah, I'd really appreciate that'd be absolutely, that'd be really helpful. I appreciate that.
Because you would think they would have a referral, you know, obviously, if they just said we can't fix you, but there has to be, and I don't know his accent, and I assume this is an indigent type patient with little financial resource, right? Probably, right?
Yeah, he's Medicaid. I mean, he has Medicaid, and
okay, so him being referred to an outside group is, I'm not sure if that would be very successful, because there has to be groups in this country, and there are, that take those kinds of patients. That's a known fact. Okay, to say that they can't fix them is they can't fix them here. It doesn't mean he can't be fixed.
Yeah, and that was actually kind of one of the things that I guess when I was griping and complaining about this and got on a soapbox, it's that, you know, here in West Virginia, of course, we are fatter, more depressed, and overdosed at higher rate. You know, we're exceptionally good at that, better than most anybody else in the country at doing those things. And it is a shame. It is a disappointing fact if we have nothing to offer people, from a comprehensive standpoint, as far as that goes. You know, it is, you know, and everybody can kind of draw their own conclusions about how I really feel about that. But it is. I mean, it's kind of disappointing. You know, we have plenty of this here to treat. So.
Well, I don't want to cut off the conversation if we have more, but I definitely think this is something that we should think about and then come back to. Definitely, whenever I hear back from everybody, I'll send the information on to you, Dr. Peters, and also to everybody, so you know kind of what's up in this.
By the way, just real quick, from a pain management standpoint, which is not to lose the focus, it's not an unreasonable. At least our pain management folks have looked at. They have done chart audits and looked at this and felt like it was. I mean, is there anything in the super morbidly obese, you know, from a respiratory that might be? He has Narcan, by the way, but beyond that, is there anything else that would be a better choice in him, like some long-acting medicine versus a short-acting medicine?
No,
as an aside, I guess.
it's not going to, whatever you do is not going to be perfect. His expectation should be, if you can help him any, he's fortunate. I wouldn't change the dose. His lung disease, and he probably has sleep apnea. That's a negative problem associated with difficulty with opioids. You're in a position I see a lot of primary care doctors in, that you can either let him suffer, which isn't good, or you can treat him and be at risk for who knows what. And I don't envy you for that, but I wouldn't change it. I think you just tell him, whatever relief you get's what you get, and this is probably the best we can do.
All right. I won't say great, but all right. Okay, Dr. Rexford, are you good to ask your couple questions?
Sure. I just was curious if there are other people in the group who are working in nursing homes. I'm the medical director at a 90-bed facility here in Franklin, and we constantly are being hammered with the fact that our residents are having, when we ask them the questions, yes, they always have pain, how are we addressing it? I feel like I write, War and Peace in the chart periodically, but, and how do you walk that regulatory tightrope when you've got somebody, you've put them on duloxetine for chronic pain, but you have to decrease it because it's psychoactive, even if you write letters and say, no, this is not, for depression, it's for chronic pain, you have to decrease them periodically. And the staff is really good about doing the, the non-pharmacologic things. I feel like we should be buying the topical lidocaine in 55-gallon drums. I mean, they use a lot of it. Where they got a blanket warmer a year or so ago, which has been wonderful. So people get TLC, and yet, we use narcotics. We have a number of people on fentanyl patches, that kind of thing, but we're not controlling their pain, and we are running afoul of the regulations because we're using too much of these medications. What's a person to do?
That's a good question. Does anybody else work with inpatient nursing home facilities?
No.
Yeah.
Wow.
You can't be the only one.
Oh well.
Well, let me talk, giving my colleagues in the pain center time to think. But I'm wondering about not chasing pain, to use Dr. Vagalante's term, not chasing zero, but in this case, maybe not even chasing pain, but picking a variable or a measure or something that you might have more success in treating, like in a nursing home, like sleep or depressed mood, where you can make a difference. And there may be some evidence, if you treat those successfully, that their pain is better as well. So kind of going at it from a different angle.
Well, unfortunately, that's another direction to fall. Maybe we're not on a tightrope. Maybe we're balancing on a pinhead or something, because sleep medicines are anathema in the nursing homes. Name me one that's not on Beer's list. I agree. I'd like to fix those other things. And the dilemma is we don't have a choice not to chase their pain, because Medicare mandates that everybody who can be asked this question, do you have pain, be asked the question every so many days. Right. And then we have to deal with the answers.
This is very tough. I don't know how to quite answer this for you. It's because you're right, between a rock and a hard place. It's a catch-22 because of the Beer's list, okay? I think you have to use your best medical judgment that if a person, an assessment skill set as a physician to assess the nursing staff, to assess the patient, to ensure that, yeah, they really truly do have pain, and then scratch your head as these are the best options that we have with, this sounds easy to say, it's tough to do, okay? And then with constant reassessment, reevaluation, and documentation as to your decisions. Because I think, you have to realize, as this group does, that the nursing home patients, a lot of those are mismanaged when it comes to pain. Or they simply lie in pain, they suffer in pain. Because no one takes it seriously or has enough time or skill set to adequately assess pain in those patients, especially the ones that are cognitively impaired, because it becomes very difficult to assess their pain. And is it then on the basis of body posture, grimace, favoring of the limb, whatever? Okay, some behavioral change, perhaps, that could be associated with pain. Then you do your best to assess that person's pain and then to try to treat it as best you can, given the fact that most of these folks are going to carry lots of baggage with respect to other disease states, lots of drug treatments, and then that becomes a nightmare to try to decide on what is the best choice for that patient. But trying to stay within the rules, too, that are governed by the nursing home, so I feel at a loss as to, how to direct you other than what I have said. I don't think I don't think those regs should have it's got to have some impact upon how you practice, but you still have to practice as a physician and you have to still take care of the patient. And that still comes in my mind first, right? As best you can. And I think if you do due diligence in your in assessment and management and documentation, then I'm not sure what else you can do, because you can't say, no one gets an opioid, okay, because of beers, because of this, and this, okay, and it may be the most appropriate choice, it may not be, it's, I guess, to, urinary tract infections in that setting, okay. You find bugs in the urine, and what's the knee-jerk reflex? You just treat them, okay? Well, that's probably not the best way of managing people. It can be said for pain, I suppose, too, but the other side of my brain says you got to believe them, too, if they're in. And you have to manage them the best way possible. And, given the confines of regulation, I still think you still should practice with the patient foremost and use your best judgment. I don't know what else to do for those folks. How else you're supposed to practice? You can't really restrict the drugs. You can't say no one gets pain. You got to find the happy middle part. That's the hard part. I think with these folks.
Yeah, a lot of them, I feel like I know how I would like to treat them, but you sort of run up against regulations. And like I say, I feel like the staff here does a good job with their assessments and with trying to provide the TLC things. I don't feel like people just lay there and suffer. I mean, but it's just difficult. And I wonder why our pain scores are always worse than other nursing homes around the state. Is it because our staff is actually asking the question? I don't know. But I just wanted to throw that out there to see if anybody had any insight.
Well, I mean, that gets to the issue of rater reliability too, right? With respect to assessment, because assessment is going to vary. I mean, if we had the same patient in front of us and we had this whole group assess the patient independent, without the knowledge of the other person, I'll bet you're going to have different pain scores, right? Because it's all based on your own judgment, experience, bias. Everything comes into the decision. So it's very conceivable, in part, that the assessments are inconsistent because it's rater inconsistency on the part of the people who are doing the assessment of the patient. Okay, and that could vary. It's funny because here in the hospital setting, I'll give you an example. With one of our patients, alcohol detox patient, okay? We were just discussing this morning. CWA scoring, okay, is very rater dependent. Even though there's 10 items on a CWA score, it seems that with some of our most recent patients, the CWA scores were worse at night or in the daytime when you have a different staff. And so they assess the patient differently. And that has implications for treatment and management and use of benzos, So maybe in part, that's part of the picture too, is the There's the inconsistency on rating.
Yeah.
I don't have a solution, obviously, but you had said you'd said the word distress and suffering. And, I'm mindful of all of our patients. When they communicate pain, they're communicating much more than a sensation. And maybe that may be more particularly true in a nursing home where you are suffering, you are in distress. And to begin to separate out those two things is really hard. And then to differentially treat them, because, and to say, okay, can I treat their distress? Can I treat their suffering? Because that's part of the pain experience.
Mm-hmm.
It's not treating the sensory aspects of pain. That is, I guess, something to think about. I don't know exactly how to do that. It sounds like the staff are great, but reassurance, attention. The other thing is, oftentimes in that patient population, it's, if a pain complaint gets you attention and support that might not otherwise be forthcoming. So, if you're lonely or you're scared or you're anxious and a pain complaint gets you attention and support, you're inadvertently reinforcing. I'm not saying they're manipulating, or I'm not saying they're
not consciously, no.
But they're responding to contingencies. And I'm sure I'm telling you something you already know, but I guess I'm asking you just think maybe about the distress and suffering of it, and maybe the nursing and support staff can intervene on that level rather than on the sensory aspects.
Hey, Carmen, this is Greg. I was just curious. I've never served as a director in a nursing home, and I haven't done nursing home medicine since I was a resident. But this Medicare, that they require this, and then you get this report, I guess quarterly or monthly or whatever it is. What are you supposed to do about that? Is that something that you get dinged by Medicare for if your numbers are too high, that sort of stuff? Because this sounds, and this might be completely incorrect, but this sounds like almost a relic of pain is the fifth vital sign sort of a thing. This sounds like just a very subjective measurement that doesn't really have anything to do with functionality. And I don't know if maybe that's true.
Well, I think it probably is, but those wheels grind slowly, and I think nursing homes are incredibly micromanaged by regulatory agencies. There's something like 15 regulatory agencies at the federal level that have a finger in the nursing home pie. And you almost can't do anything without running afoul of something. But yeah, we are expected to address the issue. Now, that doesn't mean we have to fix it. I think they understand that some of it can't be fixed, but we have to show them that, yes, I'm aware this person that they had horrible pain last week, even though I go in and ask them today and they say it's nothing. Because of course, dealing with dementia patients, you get different answers different days,
Sure, but the way that you address that can't be something like your plan is to move away from a numeric pain score and instead treat the patient from a functional perspective. You can't just divert that, because that would be my
there is a script.
Right, this is dumb, so we're not going to do that. So we're going to do this other thing that makes more sense.
No, there is a prescribed script of questions they have to ask.
You're right.
And the other one that drives me up the wall, I'll just throw out for everybody, is that they have to ask them if they've ever thought they'd be better off dead. And if the answer is yes, then I have to address that as pathological. And I don't believe that it's always pathological.
No, that's a terrible way to phrase something. I can't.
But that is the question that they have to ask.
All right.
Okay, I've finished my frustrations. We can go on to Dr. Vegley, and he's didactic now.
I have one other thought, if I can add something real quickly.
Sure.
So there was an interesting study about nursing home patients listening to music from the era of their life when they were thriving and healthy, and listening to music tied to that time in their life. And that alleviates pain and also the total pain that Cicely Saunders talks about, which Dr. Gross was talking about, which is all the psychosocial and all kind of stressors in life that contribute to pain. And so it might be interesting. I don't know if you guys use music in that setting, but it's a pretty interesting thing to make use of.
Yeah, we've kicked that around. We don't, but yeah, I too have read that study, and it intrigues me because I think it could go a long way.
Yeah, that's really cool. Dr. Rickshard, I am definitely going to reach out to some nursing home people and see about even their experience and just see. But I think both of your guys' questions today have left us with something to think about, both from the nursing home standpoint and from the bariatric care. We'll definitely keep an eye on those. And thank you. Thank you guys for coming to the rescue for my SOS email. That's what I'm going to start labeling them.
No problem.
Yeah. Okay, Dr. Vaglianti, I'm going to give you the rest of the time, and then when 1:15 hits, cut you off. Is that okay?
Yeah, that's the best way to do it.
Perfect. 2 seconds.
This is Zoom, by the way. This is Zoom.
That's how we did it with Dr. Crockett for geriatrics.
It works.
Yeah, it's yeah, it worked out really nice.
Okay, so the beginning of this has a little bit of a review of spinal stenosis, but recently we've been, as part of our minimizing opioid usage, developing different programs and being educated in different procedures that minimize the need for big back surgeries and fusions. I just read an article or saw a report of an article where between 1990 and 2000, spinal fusions went up 220%, and they have a 20 to 40% failure rate. One of the programs we developed was Fast Track Spine Care, and we put this out for acute and subacute back and neck pain, where we see your patients within 72 hours. I don't want to do a commercial, so move on. Next. So this is a depiction of spinal stenosis. On the left, you see a normal coronal view of a vertebrae. The little dots in the middle are the cauda equina and the yellow part of the nerve roots exiting through the lateral foramina. And that's what it looks like in a normal situation. On the right is a stenotic spine. And so it's multifactorial. You can have central stenosis and you can have lateral stenosis, or you can have both. The combination of this is a thickened ligamentum flavum, osteophytes on the facet joints, and either disc bulging or lipping of the vertebral body that leads to pressure on nerves, which is generally worse with weight bearing and better with rest. They have to either sit or lay down for this to be better. Next. This is what it looks like. They'll generally tell you that when they stand, their thighs feel numb or their calves hurt. And if they bend over or sit down, they feel better. This is a picture, the top picture of the vertebral bodies showing extension, how that because it closes the lateral foramina, it makes it worse. But extension makes it better because it decompresses the nerve and they feel better. That's why you'll see people come in to your office who can't stand up straight. And so that's partially this and partially a facet joint problem. Nobody really knows if there are vascular aspects to this, but I think there are, because I've had patients who went to coronary artery bypass who had back pain, whose back pain went away after their bypass surgery because their cardiac output went up. Next. So we use a continuum of care just like you do. And we live sort of in the middle two bars. So generally when we get the patients from people like you, they've already done the basic things. They're probably on a non-steroidal or a muscle relaxant, certainly on gabapentin most of the time. And then we start to do our interventional things like epidurals, facet injections, and nerve blocks. And at the end of this talk next time, we're going to discuss some of the long-term treatments for those issues in that second box. So where we're starting to play more is in this third box with various types of minimally invasive procedures, particularly the first two things, mild and interspinous spacers, to try to prevent that last bar from getting any bigger. Next. Next. So one of the things we do is called, or are going to start doing, is called the mild procedure. And so on the left, you see a midline view of an MRI, and you can see the scalloping in the lower part of the spinal canal. And posteriorly, which would be to your right, you see these big serrations sticking out, and that is osteophytes forming on the part of the facet joint and the lamina, and also thickening of the ligamentum flavum, which is depicted on the right with the red arrow. Next, please. Generally, they'll tell you they have difficulty standing and they have difficulty walking. On the left, you see the procedure at the beginning where there's dye injected in the epidural space, and it outlines those bulges which you saw in the previous MRI. And then on the right, you see that that bulge is improved because some of the bone and some of the ligamentum flavum has been removed. Next. This is data related to the mild procedure. This procedure was launched many years ago, but because there was no data, nobody would pay for it. And so they went back, the company pulled things back off the market and went back and did some randomized controlled trials. And the next two studies are those. Next. So this is busy, but you can, on the left, it describes how they did the study and how they randomized the patients, and the fact that the N in follow-up was sufficient to get a statistical answer. On the right, you'll see the dotted lines on various measures were pre-procedure, and the solid lines are post-procedure. And so I'm going to tell you that lower is better, and you see that the measures all got better. Next. This is the most striking. This is 2 to 5 years. This is the first year. The pre-procedure stand time was 8 minutes, and over the course of 6 months, it went to 56 minutes. In both of these, there's a plateau, and they think that that's probably because the patient shifted gears with respect to activity and had some conditioning issues they had to work through. But certainly anyone could see that going from 8 minutes to almost an hour of standing is significant. More importantly, on the right is the amount they could walk without pain. And they could do 250 feet, and then they go to almost 4,000 feet after the procedure. Next. This is the second one, and then after that, we should stop. Go ahead. So we showed you this before. This is particularly something that we're using now. We've done 2 of these procedures with great success, but it's way too early to get excited about it. And so what happens is we know, as we said before, extension makes it worse, flexion makes it better. So this is nothing more than a bone stop. Doesn't have any tension on the spinous processes. It's just there to prevent extension at 1 or 2 specific levels that might be symptomatic. Next. These are what they look like. They come in various sizes, obviously, for various patients. On the left lower, you see the lateral view of the deployed device. On the right, you see the anterior posterior view of the deployed device. Next. Procedure consists of this: a stab wound and the placement of a guide trocar between the spinous processes. Obviously, that has to be dead center, and it can't be beyond the posterior longitudinal ligament. Actually, I'm sorry, the spinous ligament. And so you put this trocar in, and over that trocar you place a much larger cannula. The next step is a spacing guide to make sure that you know what size you're using. And then you come out and you get the size from which you've measured, and you put the device down the trocar and you ratchet a ratchet, and it opens these wings up, and you check for proper positioning, and you're done with only a small wound. The mild procedure is the same way, only a stab wound, and there's an injection site for the epidural so that we can inject dye during the procedure to make sure we're doing the right thing. Next. This is data on this, and I'm not sure of how readable this is. Next. So this is the Zurich Claudication questionnaire, and you can see that at 5 years, there's a significant difference. It continues to get better over time. It's almost 90%. On the visual analog scale for leg pain, there's an 80% improvement. Next. And we'll stop.
That was awesome. Thank you. Questions, comments?
Does that second procedure affect posture?
No. It's, in the grand scheme of things, Jeremy, it's inconsequential because it doesn't force you into flexion. It just prevents you from going into extension.
Okay.
There's no pressure on that. There used to be a thing called an X stop, and you'd put that in and you'd crank it up, and it would squeeze the spinous processes apart. But there are a lot of spinous process fractures and things like that. There's no constant tension on this unless you extend.
Okay.
Dr. Vagliani, I have a patient. One of the reasons I suggested maybe that you talk about this today was because I heard this. I heard the longer version of this lecture at Hal Wanger and was really impressed with it. And I have another patient of mine, actually, is a home visit patient, not at all under the same circumstances as the other guy, but he's somebody who had been offered a spinal fusion for spinal stenosis at one point and was really scared off of it because he's an elderly gentleman. He and his wife are, how old are they? 80? So, yeah, not quite 80. And I had wondered if maybe that, like the hypertrophy of the ligamentum flavum and the procedure that you're able to do with that, I guess, debulking for, I'm sure I'm not using the right term, but you know, where you might be of some benefit for him. Is that who are the patients specifically for that you would target as opposed to other procedures? Like what would that patient look like?
Well, they have to have pain or fatigue with standing for a short period of time and pain with walking. And the ligamentum flavum has to be more than 2.5 millimeters thick. And right now we're only going to do one level at a time. As we get more comfortable with it, we may do 2 levels. The problem is once you do it, because of Medicare limitations, you can't go back and redo it for a year. So we want to make sure that the first few we pick are home runs.
That was great. Super interesting. We have about 5 minutes. Anything else, anybody? I want to let you guys know I super appreciate everybody just did the stuff from my call at 7:57 this morning, so thank you. All right, friends. Our next session is, I believe, the 7th of November, but I have no sense of time anymore, so let's see. Yep, November 7th. See you guys then. Thank you.